Good morning to my respected teachers and my seniors and my colleagues. So today I am presenting the background of the osimertinib after the chemoradiotherapy in stage 3 EGFR mutated small cell lung cancer. So first I am discussing about some of the epidemiology, and approximately 20 to 30% of the patient with a non-small cell lung cancer presented with the stage 3 disease at the time of the diagnosis. So the estimated number of the lung cancer in India for the year of 2022 around the 75,000. And the most common histology was the adenocarcinoma, approximately 42.6%, followed by the squamous cell carcinoma around the 15.6%. And the EGFR positivity rate in Indian population is around the 35%. So first I'm discussing about the management of the stage 3 non-small cell lung cancer as per the ASCO guidelines. The patient with stage 3 non-small cell lung cancer who are medically or the surgically inoperable with a good performance status should be offered concurrent instead of the sequential chemotherapy and radiotherapy. The patient with stage 3 non-small cell lung cancer receiving the concurrent chemoradiotherapy without the disease progression during the initial therapy should be offered the consolidation therapy durvalumab for up to the 12 months. So the durvalumab after the chemoradiotherapy in stage 3 non-small cell lung cancer, this is a phase 3 randomized Pacific trial evaluated the consolidation durvalumab for around the 1 year versus the placebo in 713 patients with unresectable stage 3 non-small cell lung cancer after the definitive platinum-based chemoradiotherapy with at least of the 2 cycles. So in this study, the patients were enrolled irrespective of the PD-L1 status of their tumors and the no progression after the definitive the chemotherapy radiotherapy, good performance status, ECOG 0 or the 1, and the randomly assigned within the 42 days of the completing the thoracic radiation. The median progression-free survival was around the 16.8 months with the 95% confidence interval with the durvalumab versus the 5.6 months with the placebo. The median overall survival in durvalumab was the 47.5 months versus the 29.1 months in case of the placebo arm. The osimertinib, another study in the osimertinib or the platinum pemetrexed in the EGFR T790M positive lung cancer. The median duration of the progression-free survival was significantly longer with the osimertinib than with the platinum therapy plus the pemetrexed, 10.1 months versus the 4.4 months. Among the 144 patients with the metastasis to the central nervous system, the duration of the progression-free survival was longer among the patients receiving the osimertinib among those receiving the platinum therapy plus the pemetrexed, 8.5 months versus the 4.2 months with the hazard ratio 0.32. Osimertinib had significantly the greater efficacy than the platinum plus the pemetrexed in patients with the T790M positive advanced non-small cell lung cancer, including those with the CNS metastasis. Another study in the CNS efficacy of the osimertinib in the patient with the T790 mutation positive advanced non-small cell lung cancer, data from the randomized phase 3 trial of the AURA3. In this study, the patient with the asymptomatic stable CNS metastasis were eligible for the enrollment and were randomly assigned 2:1 ratio to the osimertinib 80 mg once daily or the platinum pemetrexed. The primary objective for this analysis was the CNS objective response rate. In this study, the 419 patients were randomly assigned to the treatment. Out of this, 116 were measurable and the non-measurable CNS lesion, including the 46 patients with the measurable CNS lesions. The CNS overall response rate in this patient with one or the more measurable CNS lesions was the 70%, 21 out of the 30 with the osimertinib and the 31% with the platinum pemetrexed. The median CNS progression-free survival was 11.7 months and the 5.6 months respectively in case of the osimertinib and the pemetrexed platinum group. The osimertinib demonstrated the superior CNS efficacy versus the platinum pemetrexed in T790 mutation positive advanced non-small cell lung cancer. Another study of the CNS response to the osimertinib versus the standard epidermal growth factor receptor tyrosine kinase inhibitor in patient with the untreated EGFR mutation advanced non-small cell lung cancer. The CNS efficacy of the osimertinib versus the standard EGFR tyrosine kinase inhibitor in patient with untreated EGFR mutated advanced non-small cell lung cancer from the phase 3 the FLORA study. In this study, the 556 were randomly assigned to the osimertinib or standard EGFR TKI, gefitinib and erlotinib Patients with asymptomatic or stable CNS metastasis were included in this study. And patients with the symptomatic CNS mets, the neurological status were required to be stable for around the 2 or more than 2 weeks after the completion of the definitive therapy and the corticosteroid therapy. The median CNS progression-free survival in patients with measurable and the non-measurable CNS lesion was not reached with the osimertinib group, and the 13.9 months with a standard EGFR TKI with hazard ratio 0.48. And the CNS overall response ratio were the 91% and 68% in patients with more than one measurable the CNS lesion with odds ratio 4.6. The 66 and the 43% in patients with measurable and non-measurable CNS ratio treated with osimertinib and the standard EGFR TKI group.
These are all metastatic studies. Any required? Order
Another study in the osimertinib in resected EGFR mutated non-small cell lung cancer. This is a phase 3 trial, completely resected EGFR mutated positive non-small cell lung cancer. In this group, the osimertinib is used as the 80 milligram once daily and the placebo for the 3 years. Another group. At 24 months, 98% of the patients in the osimertinib group and 95% those in the placebo group were alive and didn't have any of the CNS disease. The overall hazard ratio for the disease recurrence or the death is around the 0.1 with confidence interval 95%.
Thank you, Ravinder. So basically, the background we wanted to highlight that about the stage 3 patients. The stage 3 patients, till now, the durvalumab was the standard of care, but we knew that the patients who are EGFR positive and who are PD-L1 negative do not benefit from adjuvant durvalumab. So in the approvals, though FDA had approved it throughout, irrespective of PD-L1 or other status, we were not using it, and also the European guidelines, the NICE guidelines also did not approve utilization of durvalumab in PD-L1 negative patients and also in EGFR ALK positive patients. So that was what we were doing as well. Now we have clear-cut data that adjuvant durvalumab doesn't work. In fact, no immunotherapy works well in patients who are driver mutation positive patients, especially EGFR and ALK. In ALK, the response rate is 0%. And in EGFR, the response rate is to the tune of 10 to 12% when immunotherapy is utilized. So that is the same thing which we need to take into mind while deciding the adjuvant treatment for our patients. So let's come to the patients and methods section of this LAURA trial.
Okay, good morning, everyone. So I'll be presenting the materials and methods and a little bit of the results, and then Dr. Ritam will explain all about it. So materials and methods, just a second. So we'll look at it in the following head points. The study population. The patients enrolled in this trial were at least 18 years of age, 20 years or older in Japan, and a WHO performance status of 0 or 1. The patients were histologically documented NSCLC of predominantly non-squamous pathology who presented with locally advanced unresectable stage 3 disease according to TNM 8th edition. It was recommended but not required that except for the overt clinically T4 disease, nodal status N2 or N3 should have been proven by biopsy or FDG PET CECT. Patients should have had an pre-existing local positive exon 19 deletion or L858R mutation by COBA's EGFR mutation test or centrally confirmed EGFR mutation positive NSCLC. Patients must not have had disease progression during or following definitive platinum-based chemoradiation therapy. Patients must have received either a concurrent chemoradiation or a sequential chemoradiation regimen as defined below. Concurrent chemoradiation, at least 2 cycles of platinum-based therapy or 5 doses of weekly platinum-based therapy concurrent with radiation therapy, which must be completed within 6 weeks prior to randomization. Sequential chemoradiation therapy, patients must have received at least 2 cycles of platinum-based chemotherapy prior to radiation therapy. and one or less than 5 weekly platinum-based therapy with RT, which must be completed equal to or less than 6 weeks prior to randomization. Consolidation chemotherapy after radiation was not permitted. Chemotherapy regimens which were permitted were etoposide, vinblastine, vinorelbine, paclitaxel, docetaxel, or pemetrexed. Gemcitabine was permitted if used prior to radiation, but not with the radiation. Patients must have received a total dose of radiation of 60 grays plus or minus 10%, that is 54 to 66 grays. Patients which were excluded from the study were SCLC, ILD patients, symptomatic pneumonitis. Asymptomatic pneumonitis was selected here, that is grade 1 pneumonitis was selected here. Unresolved adverse effects of grade 2 or higher after the chemoradiotherapy, which had not resolved. Drugs inducing CYP3A4 or prolonging QTC, inadequate marrow function, uncontrolled systemic disease, inadequate organ function, impaired oral intake, impairing intake of osimertinib, or hypersensitivity to the drug. Prior resection for stage 1 to disease was not an exclusion criteria, but prior EGFR TKI therapy, chemotherapy, radiotherapy, or immunotherapy for this disease excluded the patient from the study. Trial design, it was a phase 3 double-blind placebo-controlled trial. The patients underwent randomization in a 2:1 ratio to receive either oral osimertinib at a dose of 80 milligrams once daily or placebo until disease progression, which was shown by means of objective radiologic confirmation. Randomization was performed within 6 weeks of completion of chemoradiation, and all patients were certified at randomization based on prior chemoradiation strategy, tumor stage prior to chemoradiation, and China versus non-China cohort. After occurrence of disease progression, patients in both the treatment groups were offered open-label osimertinib as well. Endpoints, the primary endpoint was PFS, time from randomization to objective disease progression or death from any cause in absence of progression. Secondary endpoints were overall survival, survival without progression of CNS disease, that is CNS PFS, objective response rate, duration of response, health-related quality of life, and safety. Discontinuation of osimertinib was done when there was grade 3 or higher pneumonitis. Grade 2 pneumonitis patients whose symptoms had not resolved within 4 weeks after interrupting of study treatment. Recurrent symptomatic pneumonitis following prior dose interruption and study treatment re-challenge. QTC prolongation with signs and symptoms suggestive of serious arrhythmia. Grade 3 or higher adverse reactions that does not improve to grade 0 or 2 after withholding for up to 3 weeks. Objective disease progression as per RECIST 1.1, clinical progression, non-compliance, or patient choice. Follow-up of patients was done with CT chest and abdomen and MRI of brain. It was required in baseline and was then done every 8 weeks for 48 weeks and every 12 weeks thereafter until objective radiologic confirmation of disease progression was there. So this is the study design as I highlighted in the earlier points. Statistical analysis, PFS was assessed by log rank tests stratified according to patient's disease stage before chemoradiotherapy. The Kaplan-Meier method was used to calculate median PFS to control for type 1 error at 5%. Sorry. In order to control type 1 error at 5% two-sided significance level, a sequential testing procedure was to be implemented. And after testing of PFS, if there was significant PFS benefit, a CNS PFS was calculated, and if there was a significant CNS PFS benefit, OS was to be tested. 120 events of disease progression or death would provide a trial with 90% power to detect a hazard ratio of 0.53 at a two-sided 5% significance level, which would translate into a 7-month benefit from a median 8-month PFS on placebo. So this is the trial flow diagram. 216 patients were randomized. 143 were allocated to the osimertinib arm and 73 were allocated to the placebo arm. Of the 143 allocated to the osimertinib arm, 36, that is 25%, had disease progression. 13% had adverse events, and 20% patients died. That is 28 patients died. Of the 73 allocated to the placebo arm, 74% patients had disease progression, 7% had adverse events, and 21% patients died. Baseline demographics. So, as we can see, EGFR mutation positive lung adenocarcinomas are more common in females. So, 63% in the osimertinib arm and 58% patients in the placebo arm were female. Uh, Never smokers constituted around 71% in the osimertinib group and 67% of population in the placebo group. WHO performance status, although all the baseline demographics were mostly matched, WHO performance status 0 was more in the osimertinib arm, 56%, and 42% in the placebo arm. Stages, stage 3A constituted around 36% in the osimertinib group, and placebo in the placebo group it constituted around 33% of the total disease population. Adenocarcinomas were the most common and the predominant biology that was enrolled in this trial, 97% and 95%. Some squamous cell carcinomas were taken, and concurrent chemoradiation was the most common therapy that was offered to these patients, 92% in the osimertinib group and 85%, and some patients were offered sequential. Representativeness of the sample. So data from systematic reviews or meta-analysis show that higher incidence of EGFR mutation in female patients than male patients. The median age of patients with NSCLC was 63, and in the trial it was 62 and 64 respectively. EGFR mutations were more frequently reported in non-smokers, which was the case in this study. And it was reported more in adenocarcinomas. 92% patients in this study were adenocarcinoma. So overall, this population was representative, except for the thing that 82% people enrolled in this study were Asian. Results, we'll talk in brief about results. So the response rate in the osimertinib arm was 57% versus 33% in the placebo arm. The duration of response was, median duration of response was 36.9 months versus 6.5 months. And as you can see, the depth of response in the osimertinib group was better than the depth of response in the placebo group. There was reduction in progression in reduction in the progression events, both the local progression as evidenced by 22% versus 48% in the distant metastasis as evidenced by 16% in the osimertinib group versus 37% in the placebo group had reduced. Brain lesions, lung lesions, and new lesions, all of them were less. All of them were lower in the osimertinib group as compared to the placebo group. Median PFS, as we can see here, was 39.1 months versus 5.6 months. At 24 months, 65% of patients in the osimertinib group had not progressed or died, versus 13% patients in the placebo group had not progressed or died. So the hazards ratio was 0.16, which says that there was 84% reduction in risk of progression or death with osimertinib as compared with placebo. It was quite significant. And this PFS benefit was seen across all the subgroups. OS, the data was not mature enough to comment on OS. At the time of at 36 months, around 20% patients had died. But what was seen was that at 36 months, 84% in the osimertinib group were still alive, and 74% in the placebo group were still alive. The hazard ratio was 0.81%. This difference was seen because this difference was not quite seen because both these arms were then in later on lines offered osimertinib. As we can be seen here that subsequent anti-cancer therapy was given to 29% in the osimertinib arm and 78% in the placebo arm, with subsequent osimertinib being administered to 24% of these patients and 81% of the placebo arm patients. Treatment duration and adverse effects. So the median duration of total exposure of in the osimertinib group was 24 months versus 8.3 months in the placebo group. 23.7 months was the median duration of actual treatment exposure when the dose interruptions were removed. What this shows is that because there is not much difference between total and actual treatment exposure, it shows that those interruptions were not very significantly impairing the time that we offer osimertinib to a patient. So as can be seen here, 98% of patients in the osimertinib group had some adverse events reported. Any adverse event reported. 88% in the placebo group had any adverse event reported. Dose interruptions were in the tune of 56% in the osimertinib group and 25% in the placebo group. Dose reductions were 8% in the osimertinib group and 1% in the placebo group. Dose discontinuation was 13% versus 5% in the placebo group. The most common ADRs were paronychia, diarrhea, dry skin pruritus or rash, and decreased white blood cell count. Grade 3 or more adverse events were reported in only 19% in 19% patients in the osimertinib group and 2% patients in the placebo group. This included pulmonary lung-related adverse events like pneumonitis, ILD, pleural effusion, and pulmonary embolism. Cardiac adverse events like prolongation of QTc, reduction in LVEF, acute MI or myocarditis. Liver adverse events such as hepatic failure, LFT derangement, hematological adverse events such as neutropenia, thrombocytopenia, and dry skin, maculopapular rash, or asthenia. But what was important was that the spatial adverse reactions, which were important, especially in the chemoradiotherapy subgroup in the chemoradiotherapy population, was the radiation pneumonitis. So numerically, any grade radiation pneumonitis was present in 48% patients in the osimertinib group, but most of this were grade 1 and grade 2. Grade 3 was present only in 2% of patients. Pneumonite, pulmonary fibrosis, interstitial lung disease, and lung radiation fibrosis. If we club all of this, this was reported in 11 patients, 8% patients receiving osimertinib, and 1 patient, that is 1% in the placebo group. But again, all of these were grade 1 and grade 2 only. As highlighted in this study, although numerically the adverse events reported were more in the osimertinib group, but this was what we had seen in the earlier studies as well, and most of them were grade 1 and grade 2. Fatal adverse events that were reported in this trial was three patients receiving osimertinib were pneumonitis, pneumonia, and a road traffic accident, and 2 patients receiving placebo was myocardial infarction and aortic aneurysm rupture. Thanks.
Thanks, Yash. Now we can move to the discussion part.
Am I audible, sir?
Yes, please go ahead.
Good morning, everyone. In discussion part of LAURA trial, I will briefly touch the background, few salient points of the background and result as well. So before Pacific, based on Pacific trial, durvalumab became the standard of care. The standard of care for locally advanced NSCLC was concurrent CTRT. And this meta-analysis by Operinol of 7 RCTs of CTRT shown that concurrent CTRT improved overall survival compared to sequential CTRT, mainly by better locoregional control at the cost of increased acute esophageal toxicity. However, in spite of that, the median overall survival with concurrent CTRT was only 15 months, and 5-year overall survival with concurrent CTRT was 15%. So for a long time, there was no solution to increase the overall survival in this group, that is unresectable stage 3 NSCLC, until Pacific trial was reported in 2017. With consolidation durvalumab, we found a median PFS of 16.8 months compared to 5.6 months in placebo group, and 12 months PFS was 55.9% versus 35.3%, and 18 months PFS was 44.2% versus 27%. And in the 5 years overall survival update, it has been shown that the median OS with durvalumab was 47.5 months versus 29.1 months with a hazard ratio of 0.72. So based on this trial result, in 2018, FDA approved durvalumab as a standard of care consolidation treatment in this group. However, in this retrospective data, we have seen that durvalumab doesn't show any efficacy in EGFR mutated stage 3 NSCLC after definitive chemoradiotherapy. So in patients who received chemoradiation and followed by durvalumab versus chemoradiation without durvalumab, if in EGFR mutated stage 3 NSCLC, the median PFS was 10.3 months versus 22.8 months in group without durvalumab. And median PFS among patients who completed CTRT alone versus CTRT and durvalumab versus CTRT and induction or consolidation EGFR TKI, it has been shown that the median PFS was maximum with EGFR TKI arm, that was 26.1 month, compared to 10.3 months in durvalumab arm and only 6.9 months in CTRT alone arm. Another report, that is a post-hoc subgroup analysis of PACIFIC trial in EGFR mutant NSCLC, where only 35 patients who are EGFR mutant in PACIFIC trial. It has been shown that again the median PFS was not favorable with durvalumab. It was 11.2 months compared to 10.9 months in placebo, and median OS also was not favorable in for durvalumab. It was 46.8 months compared to 43 months in placebo. So it is evident that though durvalumab increased the PFS in stage 3 unresectable NSCLC, but it doesn't have good efficacy in EGFR mutant group. On the other hand, osimertinib became a first-line choice in EGFR mutated advanced NSCLC, that is metastatic cases, based on the outcome of FLORA trial, where osimertinib first line was compared to other TKI, first line TKI like erlotinib or geftinib, and the PFS was 18.9 months in favor of osimertinib versus 10.2 months with a hazard ratio of 0.46. And the updated OS have shown that median OS was 36.8 months in favor of osimertinib compared to 31.8 months with erlotinib or geftinib with a hazard ratio of 0.8. And osimertinib in FLORA trial also have shown efficacy in patients irrespective of CNS metastasis, but in patients with CNS metastasis, the median PFS was 15.2 months compared to 9.6 months in the comparator EGFR TKI arm. That was encouraging. On the other hand, osimertinib also have shown efficacy in adjuvant setting in early stage lung cancer based on the outcome of ADAURA trial, where osimertinib was given after surgery as an adjuvant therapy in stage 1B, stage 2 and stage 3A EGFR mutated patients, where the overall survival in overall patient population was 5-year overall survival was 88% in osimertinib arm compared to 78% in placebo arm, with a hazard ratio of death was 0.49. And particularly in stage 2-3A disease, the overall survival was 85% at 5 years in favoring osimertinib compared to 73% in placebo arm with a hazard ratio of 0.49. And not only osimertinib, other TKIs also have shown efficacy in as a induction or adjuvant treatment, maintenance treatment in unresectable stage 3 EGFR mutation positive NSCLC cases, like in RECEL trial, it's a phase 2 trial, where erlotinib, when used as a concurrent with radiotherapy followed by maintenance and compared with etoposide cisplatin-based concurrent CTRT, it has shown PFS value favorable in favor of erlotinib compared to CTRT-based cisplatin etoposide-based CTRT, and the efficacy was found consistently in all subgroups. And this is a retrospective study published in Journal of Thoracic Oncology this year, where the investigators compared the osimertinib consolidation versus durvalumab consolidation versus observation, and they have found that the osimertinib consolidation was associated with significantly longer real-world PFS than durvalumab or observation among patients with stage 3 unresectable NSCLC, and the grade 3 or more toxicity was significantly lower with osimertinib arm compared to durvalumab arm. So LAURA trial actually became like a filling in the gap between ADAURA trial of adjuvant osimertinib in early stage lung cancer and the FLAURA trial in advanced or metastatic EGFR mutated lung cancer. So I'm not going into details of baseline characteristic. Coming to the PFS data. So the PFS in LAURA trial was assessed by blinded independent central review, was significantly higher in the favor of osimertinib arm compared to placebo arm. It was 39.1 months versus 5.6 months with a 33.6 months of benefit. And the hazard ratio was exceptionally low. That was 0.16 with a p-value of with a significant p-value. And at 1 year, the PFS was 74% in favor of osimertinib arm compared to 22% in placebo arm. And 2 years, it was 65% in osimertinib arm compared to 13% in placebo arm. And this PFS benefit was consistent in all subgroups, be it age, be it smoking status, and then stage, EGFR mutation status, then a response to previous CTRT. Though the OS data was immature during this interim analysis, and 81% patient from the placebo arm was crossover to osimertinib standard of care arm. In spite of that, there was a favorable trend in favor of osimertinib with a median OS of 54 months with a hazard ratio of 0.81. And 36 months OS rate with osimertinib was 84% versus 74% in placebo arm. Coming to the response and progression, the pattern of progression. So the disease control rate was higher in favor of osimertinib arm. It was 89% versus 79% in placebo. And duration of response was also higher. It is 36.9 months in osimertinib versus 6.5 months in placebo. 22% patient in osimertinib arm progressed with new lesions compared to 68% in placebo arm. Of them, most common sites were brain, lung, and liver. But in new onset brain metastasis, it was only 8% in osimertinib arm compared to 29%, which shows the CNS protection effect of osimertinib in this trial. Coming to the treatment exposure, so total treatment exposure in osimertinib arm was 24 months versus 8.3 months is placebo arm, which includes the treatment interruptions and which corroborates with the actual treatment exposure of 23.7 months in osimertinib versus 7.9 months in placebo, which excludes the treatment interruptions. Any cause adverse effects grade 3 or more found in 50% patient, 35% patients in osimertinib arm versus 12% patient in placebo arm. And treatment interruption because of adverse events happens in osimertinib arm in 56% patients and placebo arm in 25% patients. The most common adverse events were radiation pneumonitis in both groups, but they were mostly low grade. There was no grade 4-5 radiation pneumonitis, and grade 3 radiation pneumonitis was found in 2% patients of osimertinib arm, which is consistent with the previous trials of osimertinib. The next most common adverse events was diarrhea, with grade 3 diarrhea found in osimertinib 2% patients, which is a known side effect of osimertinib, and rash was found grade 1 or 2 in 24% patient of osimertinib, which is also a known side effect of osimertinib. However, interstitial lung disease was reported in 8% patients in the osimertinib arm. Majority was grade 1 or 2. Grade 5 interstitial lung disease was found in only one patient. And this interstitial lung disease, 8% is probably because of pneumonia in osimertinib arm, because in this trial, the asymptomatic pneumonitis patients post CTRT were allowed to be incorporated. Coming to the SWOT analysis of this trial. So strength of this trial shows superior PFS benefit with a median PFS of 39.1 months versus 5.6 months and an exceptional hazard ratio of 0.16 with a reduction of progression by 84%. There was a protection against CNS progression. CNS progression was only 8% in osimertinib arm versus 29% in placebo arm. And there was 81% protocol crossover from placebo arm to standard of care osimertinib on disease progression, which is often preferred in such phase 3 trials. Though the overall survival data is immature with only 20% maturity data of overall survival, but there is a favorable trend in favor of osimertinib with a 5-year OS of 54 months and the hazard ratio of 0.81. And the toxicity of osimertinib is consistent with previously reported osimertinib trials, and this is manageable with no new safety signal. However, there are some weakness or some questions arised after this trial was reported or presented in ASCO 2024. The first one is 81% crossover in control group. So there is a chance that this 81% crossover to osimertinib arm subsequently might impact the overall survival data. Second fact is this trial allowed treatment until progression. So the question is whether we are studying osimertinib maintenance versus placebo, or we are studying osimertinib maintenance versus osimertinib on progression. And if we treat unresectable stage 3 disease like a metastatic disease, then what is the additional benefit of chemoradiation in this group, and whether we can use osimertinib upfront and only as an alone treatment for this unresectable stage 3 disease. And what will be the cost effectiveness and side effects or quality of life concern with this indefinite therapy. The third fact is PACE-CT was not mandatory for baseline staging of this trial. So there might be some baseline understaging and that could be a potential cause of poor performance in placebo arm, though the median PFS in placebo arm was consistent with the results of placebo arm of Pacific trial and Gemstone 301 trial. To explain the treat to progression approach, the investigators said that adjuvant EGFR TKI trials in EGFR mutated disease, like adjuvant trial or radiant trial, showed that Kaplan-Meier curves of DFS converge or declined after completion of the planned trial treatment for up to 2 years. So in unresectable stage 3 disease, the same effect was observed in RECEL study also, where Kaplan-Meier curve for PFS in erlotinib plus radiation group started declining at approx 24 months. So this suggests that patients may benefit from a longer treatment duration to ensure that they maintain a disease-free or progression-free state. In addition, in unresectable stage 3 disease treated with CTRT alone, PFS rates are poor, and there is high incidence of distant metastasis, including CNS mets. So this supports the clinical benefit that long-term treatment, adjuvant treatment with EGFR TKI may provide a curative intent treatment. Coming to the opportunities out of this trial, so as the intent of this treatment or approach of this treatment is to treat till progression, so we need to know which patients are prone to develop recurrence, and at that point we can stop the treatment or change the treatment. So this is a new concept of molecular residual disease, which analyzed from ADAURA trial of adjuvant osimertinib, and this has been presented this ASCO 2024. where we already know that ctDNA detection in early stage NSCLC and adjuvant settings can be challenging due to low tumor burden. But it has been shown that studies in early stage disease support that use of tumor-informed MRD assays using high-depth NGS. So here MRD means MRD detected in plasma suggests that clinically undetected cancer cells, which can be a biomarker for early disease recurrence and could inform treatment and prognosis. So in ADAURA trial, ctDNA sampling for MRD was done at baseline, and during adjuvant treatment of 3 years, it was done every 12 weeks. After 3 years, it was done every 24 weeks, and after 5 years, it was done every 52 weeks or annually. An MRD detected classification was made when plasma ctDNA tested positive for one or more mutations in tumor-informed panels, regardless of the MRD status at baseline. And then MRD status was assessed in relation to DFS events, that is clinical recurrence or death, in both osimertinib and placebo group. So it has been seen that MRD events were detected more frequently with placebo versus osimertinib. So 13% MRD events were occurred in osimertinib group compared to 49% in placebo group. And DFS and MRD event-free status was maintained for majority patients of osimertinib group, that is 75%, during the treatment or during post-treatment follow-up. Whereas in placebo group, only 31% patient maintained MRD event-free status or DFS. And this tumor-informed MRD in ADAURA trial identified recurrence with a median lead time of 4.7 months. In LAURA trial also, the secondary endpoint is ctDNA-based MRD. So that is the opportunity to apply this MRD concept. The other opportunities are other EGFR TKIs to use in unresectable stage 3 EGFR mutated NSCLC. So the ongoing trials are of 2 drugs. One is aumolertinib and another is lazertinib. So lazertinib, the platinum trial, is the single-arm open-label phase 2 trial of CTRT followed by adjuvant or maintenance lazertinib until disease progression, with a primary endpoint of PFS, and this study is ongoing. The other trial of aumolertinib is advanced trial, which is recently presented in ESMO lung conference, where aumolertinib was used as an induction therapy of 110 milligram per wall OD for 9 weeks, followed by radiotherapy with aumolertinib concurrent, followed by maintenance aumolertinib till disease progression. And it has been shown that aumolertinib in aumolertinib group A arm, the median PFS was not reached compared to 6.2 months of median PFS in only CTRT arm. Coming to the threats of this LAURA trial in SWOT analysis, apparently there is no major threats. Only the concerns are immature OS data. There could be development of drug resistance because of early use of osimertinib in adjuvant setting. And though the radiation pneumonitis higher grades were less in this group, but still ILD and pneumonitis still poses a challenge when we use osimertinib in adjuvant setting following CTRT. So to summarize, in this primary analysis of phase 3 LAURA trial, osimertinib significantly improved PFS with a PFS benefit of almost 33.6 months and the hazard ratio of 0.16, and the PFS favored osimertinib across all patient subgroups. Though interim OS data were immature, but it suggested benefit with osimertinib despite 81% of crossover from placebo arm to osimertinib. The safety profile of osimertinib after definitive CTRT was manageable with no new safety signals. So from this data overwhelmingly favoring osimertinib, osimertinib should become a new standard of care for patients with unresectable stage 3 EGFR mutated NSCLC and no disease progression after definitive CTRT. However, EGFR mutation testing is vital in stage 3 disease to identify patients most likely to benefit from this osimertinib. And additional analysis and follow-up related to this current trial would be of interest in terms of final overall survival, CNS progression-free survival, safety, health-related quality of life, and exploratory analysis based on circulating tumor DNA. And future research on the efficacy and safety of other EGFR TKIs, either as induction treatment before chemoradiotherapy or concomitant with chemoradiotherapy in this disease setting will also be of interest. Thank you.
Thank you, Ritam, for this nice discussion. Most of the important aspects was covered in this discussion. Most importantly, the very important opportunities were discussed regarding this MRD detection by ctDNA-based approach that has become much more relevant in such settings where indefinite adjuvant is being recommended actually. So this was a very important and nice discussion. In fact, it seems that ctDNA will become very rapidly the standard of care approach in all the adjuvant settings, where the patients who are not getting ctDNA negative will be continued on adjuvant treatment, and who are getting ctDNA negative at least 2 times, at least 2 to 3 months apart, they can be stopped adjuvant treatment. I think that era is rapidly coming in solid tumors, and lung might be the first area where this could happen, apart from the colorectal cancer where this was being studied from long, but till now it could not become the standard of care. But in lung, I think these things have been taking shape much faster and in much better way, by which the standard of care based on ctDNA testing might change. This was a very useful discussion part. Thank you, Ritam, for that. Any comments? Any comments? Amit Joshi, sir, would you like to comment on this discussion and this trial?
I think very well summarized by Ritam. I think the only challenge for this study is that the duration, I don't know why they have not defined the duration. So the discussion of a real adjuvant versus maintenance is the real challenge of this study. If they would have defined, or some sort of a stoppage rule by any means would have been the, because, and I think we have to wait for the OS data. Suppose the crossover seems to be very much consistent with close to 81%. Suppose that if the OS doesn't come in the favor of the adjuvant osimertinib, then whether to give early or give at the time of progression will be the question. So I am not sure why they have continued till progression. That defies the rule of the adjuvant whenever we plan. Adjuvant means for a limited period of time. The other question is that in the other phase 2 trial of erlotinib, I was just forgetting the name, the trial from the R something, reveal trial or something. Result trial. So what was the duration of TKI in that study? How long
2 years.
They have given?
2 years. 2 years.
2 years. So I think
yes, sir.
That is, I think, most. Otherwise, from the toxicity point of view,
the good thing is that in that trial they give erlotinib along with radiation as well,
Okay.
and also, yes, sir. So they didn't give concurrent chemo radiation; they give concurrent erlotinib with RT.
And what was the lung toxic? What was the pneumonitis? That is some of the fear in our mind during TKI. So
correct, sir. Correct,
have
sir.
they
So,
published full paper for that? Full paper for that data?
No, sir. I think that was presented in ESMO last time. Ritam, can you show that slides? So RESEL trial is actually worth a discussion.
It seems to be much relevant to our scenario currently. Yeah,
correct, sir.
And we can implement that now. Ultimately, how many will afford at this point of time? But erlotinib definitely we can give to any patient. So in a day-to-day setting, if some patients who is EGFR positive and adding erlotinib, definitely we can. That is much here in our adopting in our day-to-day practice rather than osimertinib.
In the next slide, do you have more details? Yes, sir. Phase 2 RCT. It has been published in IJROBP in 2021 itself.
I think we need to check the data for this. Seems to be encouraging in terms of the design and the.
Yes, sir. Only thing is that 40 patient study, a small study.
Yeah, so
Yes.
that is an opportunity for us to increase the number in this group.
Yes. Yes, sir. Yes, sir.
So I think now the
Yash, I think in Yash slides there were more details of this trial. Yash, can you share the design of this trial, the result trial? Ritam, you can stop sharing and request
sir.
Yash to share. Yes, so completely agree. This result trial was very.
I did not have this. Sorry.
Okay.
So actually, this trial was
Fine.
presented as an abstract in 2017 ASCO. So in that abstract, they have mentioned that the incidence of adverse effects was similar to two arms, but the most common toxicities was grade 3 or more were rash and hematological toxicity. So rash was 20% and hematological toxicity was 26%, but they didn't mention about radiation pneumonitis as a grade 3 or more toxicity, serious adverse events, even in allotinic plus RTR.
Okay. So when phase 2 data is already available, I think a phase 3 study, if not being ongoing in other parts of the world, this is an opportunity for our centers to consider such a study, because completely agree with sir. Osimertinib is having patent protection till 2032. So
Oh
that
God.
will take a very long. Yes, sir. So till 2032. Yes, sir. So 8 years from now, we are very away from getting generics of osimertinib, the approved generics of osimertinib at least. So this is definitely an opportunity. And in this trial, with the yes, sir, this LAURA trial was so small trial as compared to other trials of adjuvant actually. So the trial of Pacific had 700 plus patients. This trial had only 234 patients, 2:1 randomization, and 143 and 74 patients in the two arms. So this is not very difficult to conduct in our settings. So that is also very meaningful. Yes, sir.
I think one thing is sure that the adjuvant is helping in lung in all setup, whether it's a post surgery, post RT. So I think now the immunotherapy has also come in big way in adjuvant setting. So one thing is sure that the only question is that which patient is going to. I think what you told about the ctDNA is definitely the future. That do all patient needs adjuvant treatment? So I think that is the future for next studies, that can we prioritize the patient, or can we segregate who needs adjuvant or those who do not need it adjuvant. So I think this is the high time for the ctDNA studies to come into the practice, and as you told, that is the future, and I also feel is the future for the way to go ahead, because do all patient needs intensive care treatment? The answer is no. But how to identify those groups of patients which need the treatment? The ctDNA is the answer. Very nice.
Thank you, sir. Thank you, sir. Any other comments? Kumar sir, would you like to make some comment?
Akhil, it was for me, you said?
Yes, sir. Yes, sir.
अच्छा, it was nice presentation. मैं बीच में नहीं था, लेकिन बीच में मैंने सुना था. It was very nice. I agree with Amit's comment. Now finally we have multiple evidence that in adjuvant setting targeted therapy works, and now it will be tough to ignore. And now the problem for me is, what do I do when you have those ROS1 positive, NTRK positive, RET positive? For last 1 month, I'm dealing with one patient with RET positive, and the discussion went on, and that patient took a RET positive therapy, because by the time ALK data had come in adjuvant setting.
Yes.
Now
Yes,
we have
sir,
a lot of so slowly that concept suggests that there's a merit in when you have those very effective treatment. I'm sure, I think so. Maybe this not the same result for KRAS, but for these drugs, for EGFR, ALK, ROS, RET, and NTRK, looks that they are a different category of TKI, and it works in wherever you put in.
Yes, sir. And
And
even
also, erlotinib, that data has been there for some time. We have explored in some patient, not
Okay.
with CT-RT, after CT-RT, that we didn't do it. After
Yeah.
CT-RT, in some patient we have given, so and that is something which we may keep in mind to explore about in our OPD.
Yes.
But again, phenomenal drugs, we have never seen, our time hazard ratio, I hope Amit is on, and Dr. Vanita is there. In our time, hazard ratio 0.8 used to be important. I'm telling you, I remember, acha, iska 0.84 hai. It is good hazard ratio. That was the discussion used to happen that time. Now you have 0.19.
Yes, sir.
So these kind of hazard ratio we have not seen in the past. And Akhil, also you might have been seeing in recent years. Huh? I don't think so during your training time you might have seen
Correct,
such
sir.
good hazard ratio.
So in last 3 to 4 years, we are seeing multiple data sets having hazard ratio of 0.16, 0.18, 0.19.
And I'm telling you what this did. That was something very striking for me. The whole lot of people used to talk about DFS and PFS as a issue, as a primary endpoint. Now slowly you don't hear that. Now if you see last when a few years back, when the trial for osimertinib came in adjuvant setting, there was a whole lot of discussion online everywhere. Did we hear in Alina trial? We didn't. Did we hear in Laura trial? We didn't hear those kind of criticism. Initially, it was like, oh, it is just DFS and endpoint. Should we take it in the clinic with based this kind of data? But looks that when the drugs are so effective, slowly people reconcile that this is a good endpoint. So very good
Now,
discussion.
sir, the question is,
Go ahead.
now the question is coming up, do we really need CT-RT in patients who are EGFR positive?
I'm telling you, this was last 1 week back or 2 weeks back. One of the residents raised this issue. Laura trial came and then the resident had raised the issue in the OPD. कि PFS तो देखो सर 6 महीने वहां पे आप CT-RT दे रहे हो and उसके बाद oral tablet देते हो, PFS is 34 months. Yeah, 34, 36, whatever, maybe, But then say, do we really need to give it or we should give it later on? As and when required. I agree with you. That will get challenged. Now I'm more. We used to talk about it again. Amit is and Dr. Vanita will be there. We used to talk about it. When the initial TKI data came, that the staging of the patients. So stage 4 patients, the median survival being around 30 months, and stage 3 patient median survival being around 17, 18 months, based on relatively older data for CT-RT. Say, hey, stage per stage, do we club them in a different group? Outcome is similar. And now it looks okay. This treatment will be changing the paradigm, the way we manage today. And in fact, that issue keeps coming up. Adenocarcinoma patient, this was last week. Borderline resectable. Borderline for radiotherapy. So this question came, do we do mutation testing if TKI or give chemotherapy and then plan for CT-RT? I don't know. So that discussion will happen more and more. Agree with you. Thank you.
Thank you. Thank you. So, Mishra sir, any final comments, sir?
So I think it was an interesting discussion, and as Dr. Kumar said, that now we have to upfront deal with all receptor positive patient, whether EGFR or positive. And in fact, one more thing, that those patients who cannot afford osimertinib, we can even try with gefitinib, avalotinib also in our real world setting also. So this may be an opportunity to the patient who cannot afford this costly treatment. At least we have some evidence that this can be done and differently in our patient, which maybe we can give our many patient in our setting.
Thank you, sir. Any other comments else? So we can close. It's 9:30 already.
And just saying hi,
I
Mr.
think-
Ji. Good morning.
Good morning. Good morning.
I think we are reaching to a stage where I think at least in stage 3 or in some stage 2B, maybe surgery may be out. So, so the survival for a stage 3B is treated with a CTRT followed by durvalumab or by the it may be better than treated by surgery alone of a stage 2 if we directly compare. So the question that whether do we really need surgery in stage 3 or 3A also? Can we get away with that? That will be the next question, I think.
Some similar questions will keep on cropping up, and unlikely there will be direct answer. But yes, the depending on the status, fitness of the patient, and the patient's willingness for tolerating the toxic treatments, a decision might be taken. Thank you, everyone. Thank you. We'll close now.